it looks different for different people. Some people get weeks, months, days, hours without any intrusions. And then there's people like me who get them constantly. I get intrusive thoughts every hour, multiple times per hour. There are people who can get medications that help really reduce the intensity. And there are people like me who are medication resistant and have to rely 100% on ERP to keep me going.
Welcome to recoverHER, the podcast where your healing journey begins. I'm Heather Novak, and I'm here with my co-host, Dr. Tracie Ibrahim, a compassionate psychiatrist. Today, we embark on a path of recovery and self-discovery. We are dedicated to inspiring each and every one of you to overcome your struggles and live your best, most fulfilling life. Your recovery starts now, and we're here with you every step of the way.
It's only up from here, 'cause there's no one else that's me.
Well, welcome back to recoverHER.
We're here.
Let's do this. Today we're going to get down and dirty with a super fun guest.
Sounds good to me.
So today on recoverHER, we're pulling back the curtain on a topic that far too often stays hidden in shame. Taboo, intrusive thoughts, and OCD. Obsessive-Compulsive Disorder. Our guest is Tracie Ibrahim, known online as Taboo Tracie. She's a licensed therapist, the chief compliance officer at OCD, and a fearless advocate for those living with the darkest corners of OCD, thoughts of harm, sexuality, religion, and more. But before she became a nationally known expert, she has had her own journey with mental health, which I'm sure we'll get into. With clarity, courage, and a healthy dose of humor, Tracie is changing how we talk about OCD. Today, we go deeper into what ERP therapy really looks like, how to live with uncertainty. I just felt anxious when I said that. And why naming our scariest thoughts might just be the beginning of freedom. This episode is about truth, stigma, smashing, and reclaiming the stories we've been told to fear.
Welcome, Tracie.
Thank you. I'm excited. There is nothing better to talk about than taboo topics.
I agree with you.
Tell our crew how this became your destination in life.
Yeah, it's I backed my way into it. It wasn't like I was born knowing that I was going to be Taboo Tracie. It strangely started, well, I guess we'll talk about my OCD journey eventually, but I didn't know I had it, so it didn't start then. But when I was in my undergraduate, studying for psychology, and I just started taking a couple different classes, and I went to Indiana University, and they have the Kinsey Institute, which has a bunch of sex things there, sex information and research on sexual things and all kinds of taboo-y things. And I took a class, and it was very triggering to me. They talked about lots of different sexuality things and sex things, and I was just cringing in my soul, thinking, you're going to be a therapist one day and you cringe at these topics? And I was like, of course I cringed. Like, I grew up in a Jewish family that didn't talk about it. It's not the Jews' fault. This is just my family. Where I remember my grandma asked me a question once, just as an example. She's like, Tracie, are you being careful? This is just out of the blue. I'm just at her house. And I was like, what?
Are you being
I'm
careful?
just watching TV. I'm teenagers. Like, are you being careful? And I was like, what? What am I doing? I'm sitting in a chair. I'm fine, Grandma. And she's like, no. Are you being careful? And I was like, what are you saying? Like, this sounds weird. I don't know what you're saying. She goes, about a little thing called sex. And I was like, and we were both horrified in that moment. Like, I was horrified that she spelled it and that's what she was talking about. And she was horrified because she had to spell it. And that's how I grew up. We did not discuss these things. I grew up in a house where my mom left a book on my bed once. and the explanation for sex was this, or babies. You got to a page and it was like, when a man and a woman love each other, they lay near each other in bed. Then the next page, they had a baby. And I was like, very informative. Thank you.
Oh, shit. Yeah.
Yeah. So, I mean, this is like my entire upbringing. So it was like pretty much nothing. We will not talk about it. We will not discuss it. We will know nothing about it. So knowing that I was becoming a therapist and I was that nervous, and I was like, my biggest fear is I was going to start laughing if somebody brought up a sexual topic.
Okay.
Because laughter is my nervous thing. And so I was like, maybe I should take some more classes.
Hey, Tracie, can I ask you something? Do you think your grandmother knew my grandmother? Because once I was rolling down the street in West Bloomfield, Michigan with my grandmother driving. I don't know. I was maybe 14, 15, not quite sure. And out of nowhere, he says, "So? Tell me." And I said, "What do you want me to tell you? What do you want me to tell you? How do two women have sex?"
Oh.
And I thought,
ah. Did you tell Grandma?
No. And you know what she said? She said, "I've been educating you for 15 years. Now it's your turn to educate me."
Love it.
Yes. So you're continuing your education.
Yeah, so I was like, no one's going to educate me. So yeah, I started taking more and more classes that were sexually informed while going there. And then I went over to the Kinsey Institute, and I was just like learning things and pulling stuff. And I was so uncomfortable. So when I got to grad school, I was like, how are you going to be a marriage and family therapist that never speaks of sex? Again, nervous. So I took so many classes that I ended up getting comfortable with it. And then I ended up becoming a certified sex therapist. And this is funny. At my grad school program, it started out, there were a handful of us in the sex therapy certificate program. I'm the only one that made it out.
Oh my
God.
God.
Only one.
I was the only one at the end of it. It's just every semester it shrunk. And I was like, what? Can I help teach your class on BDSM? Are you going to be out next week?
That's
and it was like
classic, Tracie.
Opposite. And
Good
so
stuff.
That's what really flipped it for me. I was like, nobody wants to talk about this. I'm comfortable now. Who wants to talk about it?
Right. Then you want to talk about it all.
I want to make it comfortable.
That's good.
So that's how that happened. Yeah, that's how that actually happened. I wasn't like going to school to do that or anything. I always go toward things that make me nervous.
So, and I love that about you. Let's talk about the basics. Educate me a little bit, or our entire audience, about OCD.
Sure. OCD is not all the things that people think it is. I like to say that first, right? It's not an obsessive Christmas disorder. It's not being neat and tidy. It's not being the most amazing organizer with the best closet. Because if you have the best closet, it costs you a lot of pain to get it that way, and it actually sucks deeply. So
that narrative you found to be not only harmful, but inaccurate. Because I've heard that a lot. Like, I'm so OCD. You know, people just say it so cavalier.
I'm a little OCD, yeah. And it always freaks me out. I'm one of those people that will stop and like do like a 180 and look at you and be like, let's talk about it.
Right.
Are you talking about you have a little bit of pedophilic OCD, or do you have a little bit of homicidal OCD? You know, and they're like, what?
I love her.
I'm like, you're about to get schooled because you said you have a little bit of OCD. I will freak out in front of an entire audience.
All right. So go on. The basics of OCD.
So what is OCD? OCD is... it is a neurological, it's in your brain. Easiest thing to say is it's a broken alarm system that goes off. It's the same one that tells you there's a real emergency when you have a real emergency. It goes off and it sends a message to you that something is seriously wrong and needs to be solved immediately. Something is dangerous, something is bad, and you get what I like to call a chemical shower. So to help you react. So if I heard a breaking glass in the other room right now and a scream, the same system would go off. I would have an alarm go off, and I would get all the chemicals and hormones, the adrenaline, to get up and run and save whoever fell out the window or whatever was happening. But with OCD, the exact same process happens, but there's nothing wrong.
Oh, my.
Or you're blowing it way out of proportion.
Got it.
So and your brain doesn't know the difference. It cannot identify this is an OCD thought versus it's a different type of thought. So it feels serious. It feels real. Everybody gets intrusive thoughts. The difference is with people with OCD, we feel like it's real and we feel like we have to do something about it. That's the difference. If you just get a passive thought, I want to blow up everyone in traffic so I can get past, the 5 freeway or whatever it is you're stuck on. Everybody can have that thought, but when you go, oh my gosh, am I a murderer because I had that thought?
I see.
You've crossed the line into OCD now.
Got it. Okay, that makes sense. What a good explanation.
Yes, I think so often people associate obsessive compulsive disorder with cleanliness, right? Like
or perfectionism,
or a fear of contamination, which certainly is part of it, but it's just the tip of the iceberg. So often what's portrayed in the movies or on TV shows is you have someone that's afraid of getting contaminated and they wash their hands a lot. But there are much broader thoughts and compulsions that people deal with, and I think Tracie's name is so appropriate, the tabooness. Sometimes when people seek mental health, although oftentimes you don't, the person's not comfortable sharing these things because they feel so much shame around it. They really feel like something's terribly wrong with them. But worse is that the provider is not comfortable asking about these questions, or may not even know to ask about those questions. So in my training, we had a very big OCD program at the University of Michigan. So I'm fortunate for that, but so often people will come see me who have been dealing with OCD lifelong, but haven't gotten properly diagnosed. Yeah.
No, that's absolutely true. And I also think it's important to note that, I have contamination OCD. It's actually my worst theme. It's way worse than my suicidal or homicidal OCD, which people are like, what? How could it be worse? Because it affects me in a real way, in a different way than the other ones do, actually. Because I have to always go in a bathroom, and bathrooms are the most disgusting place for me. And people are like, oh, well, just wash your hands 8 times. Well, I don't have a hand washing compulsion. I don't have compulsions anymore because I have been treated. But, I used to hold in my urine at work to the point that I got bladder infections or UTIs because I didn't want to use the bathroom at work. People are like, haha, contamination, avoiding a bathroom. Is it funny? Because I kept getting medical problems about it. Is it funny? Because I used to pull over on the side of the freeway on a long drive and go into like the weird weeds of the freeway to use the bathroom, to not have to use a public bathroom. There's nothing particularly hilarious about that.
No.
And, it kind of sucks, actually. And also, I'm not a super neat person, by the way. I have piles of things sometimes, and I'm not well organized. Everybody with OCD is not well organized. And if you went into my pantry while I was very super compulsive, it was compulsively organized, which someone else might say, well, that's delightful, but it was great distress for me. If somebody picked up a soup can and put it in the vegetable area, I was like, who has done this and messed this system? Like, I don't feel okay anymore. It got to the point where no one else was allowed to put away groceries, and no one's allowed to be in the kitchen, and no one's allowed to do. People don't see the other side of it. They're like, oh, that's cool. It's super neat. And like, you have a super tidy, whatever. You don't see the pain and suffering behind how neat and tidy something is. It's not a delightful trait.
I think the first time I really had an appreciation for how devastating it could be was there was a woman hospitalized on an inpatient behavioral health unit when I was a resident, and she had recently had a baby, and believed that she was going to hurt the baby because she was having these worries that she might do something to harm the baby, and so she would not allow herself to be near her child, or even in the same house, which obviously was having devastating consequences for her and of course her baby. But when you hear, because obviously you can have postpartum psychosis where you're having, very dangerous thoughts, of course, but that was not what was going on for her. It was related to OCD that had greatly intensified in the postpartum experience, and she had never formally had a diagnosis of OCD, and a lot of physicians, were misdiagnosed her for a long time, and so it had significant consequences. Tracie, why do you think people don't know, not only just humans roaming around, but like therapists, psychiatrists don't know about a lot of these other, pedophilia, harm? Why do you think we don't know about those things?
So that's actually something that is one of my advocacy efforts. I've gone nowhere with it, by the way, but this is the problem, because I can't solve it alone. I guess people are not being trained appropriately, including myself. I was not trained appropriately. I didn't come out of the gates knowing how to treat it or what it was. It took me many years. So, I mean, just take like a look at textbooks that most people are learning. Most people going into the mental health field, therapists, psychiatrists, we're not learning what OCD is, and we're also not learning how to treat it. And when I say that, some of us are learning how to treat it wrong. So everybody I know, except for you, actually, who went to University of Michigan, which I wrote it down. I was like, University of Michigan teaches properly. I'm going to put that on my list of model places. We were taught just to use straight CBT treatment for our OCD, and that OCD is checking, hand washing, germs. I think we spent 20 minutes on it in my grad school. And use CBT. Well, we can't use CBT. It's not a logic disorder. You're not going to give me the right amount of logic, and then I will logic my way out of this. It's not a logic-based disorder. So actually everybody I know, except for you and one other person, had never heard about the real treatment or real anything, and we had all learned the wrong way. I am totally baffled why that exists. I don't understand. If there is a gold standard treatment, and we all know what it is, why is it not in the textbooks that are training people who are supposed to go out and help people? I cannot answer that question. Maybe it's like a textbook / school thing happening.
Listening to you both speak about OCD, I was going to ask you a number of questions that you keep answering before I have an opportunity to ask them. So thank you for being so thorough about intrusive thoughts and what OCD is. And my next question, I just want to know, how does it affect, if you suffer from OCD and compulsive thoughts versus normal experiences? I know that of course seeps into every area of your life. How does that affect relationships? And you brought up sex and partnerships. What do you see with the people that you treat?
I would say that every single presentation, while there are similar things across different people, it affects everybody differently. How does it affect relationships? There's a relationship OCD. You could have just relationship OCD, just about your relationships. You could have contamination OCD, but it leaks over into your sexual relationships because you're thinking about the contamination of being with somebody and their bodily fluids.
Or parenting OCD.
Right. So there's all these different ways that it can intertwine depending on your life and your presentation and the different things you have going on at any given time. There's just, because it comes up in so many ways. And then for everybody, it's a little bit different. We won't get too complicated, but most OCD exists in the fear space. Contamination exists in a fear space, but there's also a disgust space, which is a different part of your brain. And I have that kind of contamination OCD. So it's not fear-based. I'm not afraid of getting sick. I'm not afraid of getting other people sick. I'm just straight disgusted by the thought of poop germs, or being involved in poop germs. So how does that affect me? It affects me in the way that everywhere that I think there are poop germs, I feel disgusted, and I'm trying to like figure out how to get around that situation versus my other themes, which are fear-based themes. Um, you know, they just present differently. So everything can just intertwine and turn into a hot mess. But some people only have one theme and it affects multiple areas. Some people have multiple themes of OCD. Some people have rotating themes.
So, what are some of the more evidence-based tools to help combat the daily living when you suffer from OCD?
Gold standard treatment is exposure response prevention therapy.
Wow, that has to be hard.
ERP. A lot of people do think it's hard. It's actually not that bad. If you are with a practitioner who knows how to
What
do
they're
it,
doing,
it's really
right.
not. Because you start very small.
Give me an example of that.
I will. And to say that exposure response prevention therapy not only is the gold standard, but it's been around for decades. And nothing has been proven in terms of a therapeutic technique to be better than it.
Okay.
Even though there's a lot of things out there purporting that it is. But the most evidence-based treatment is that as far as therapy. Medications that are the right medications at the right doses, again, mixed with ERP therapy, because you have to behave your way out of OCD. So ERP is under the umbrella of CBT therapy. What it looks like is this. You have a very thorough assessment done by a professional. We figure out where your fears are, what are your fears? What are you doing? What are your obsessive fears? And what are the compulsions that you're doing in response to those fears? We build what we call a hierarchy or a fear ladder. We start all the way at the bottom. Number one, what is the least scary thing about that thing? Whatever it is. Like for me, like let's just say thinking about using a public bathroom feels very low. So the first exposure we might do is just sit and think about being in a public bathroom.
Mm-hmm.
Okay, that doesn't feel super hard. It's kind of gross, but it's a little bit.
Sure.
And what we deal with is what we're looking for in this process is called habituation or inhibitory learning. It's kind of complicated, but basically you learned that you can coexist with yucky thoughts or situations and that they will not have the outcome you think they will. It's not as catastrophic. Okay. So we learn tools to manage through it without compulsing.
Got it.
And then in ERP, you build up. You start going up to higher and higher levels. But as you get higher up, it's not as scary as it used to be because you've been climbing a ladder. So just to be clear, because a lot of people are afraid of ERP, they think we're going to go lick toilets and jump off of things. And it's not that. It's not that. And we would never just jump into that. It'd actually be the opposite of helpful. So good thing to tell people.
But ultimately you will climb you will climb up there. You can, climb up there. And I think about Dan Fisher and Joe Himley who helped train me, and they were some creative guys. I was like, to have effective ERP, you're coming up with ways to really really challenge people, and we won't name any names, but someone we love so much has this worry about what if I'm gay and I don't know it, and so you can come up with some really creative exposure response prevention around that, so driving around with a pride flag in your window, or going to the Castro, things like that. But I think the most important part of what you're saying is sometimes people with good intentions will engage in exposure response prevention with a poorly trained therapist, and they'll have them take their fear to a 10 out of 10. So they'll get really ramped up, very anxious, very uncomfortable, and then the person will be overwhelmed and flooded, and then not re-engaged with treatment, or people don't know that you have to habituate in terms of let your anxiety choose the level of anxiety that you're going to bring on so that you can let it come down versus overwhelm your system. So you have to stay with it for a long enough period of time. You can't just dip in for 2 minutes and then dip right out. So it's
like all things in life, it takes a little practice. It's progress, not perfection.
Mm-hmm. And then can you explain to people, so compulsions, right? Like, so that the acting out of the compulsion, and then just the mental compulsing, because I think some people don't get diagnosed appropriately because there's no outward action.
Absolutely. Yeah. Mental compulsions are very misunderstood, as are, I think, a lot of different things that people don't realize are compulsions. So mental compulsions, most commonly we call it rumination, or, mental review, trying to figure out, like, that last year when this thing happened, what if I blacked out and I did something that I regret? And keep trying to figure that out, trying to remember, trying to think about it. That's like a mental review. That's a mental compulsion. It could be trying to figure out how you feel about something. How do I feel about it at that time? What was I thinking at that time? Could be something like outwardly, like seeking reassurance. People don't realize that is a compulsion. Hey, Tracie, do you think that I would do something like that? That's a compulsion. Their avoidance is a compulsion. Me avoiding using public restrooms was a compulsion. And again, it's a silent compulsion, but nonetheless a compulsion. Trying to thought neutralize. I had a bad thought. Now I'm trying to replace it with a good thought. Trying to block thoughts. People will tell people, just don't think about it. Well, nobody controls their thoughts. That's not possible. And you can't neutralize. Like, people will be like, well, how? I get this, my most common question I get. But how do I stop getting those thoughts? I'm like, you can't. All you can do is learn how to manage successfully without compulsing when you get them, and not label them as bad. They're just thoughts.
Do you see OCD present itself differently in women?
Not so much.
Not so much.
mean, maybe in certain little caveats sometimes when it's like perinatal OCD, or, but even then, not really. I mean, I have like men that'll move out of the house because they're afraid that, they're going to harm their children. I wouldn't say that there's necessarily sexual orientation OCD. Am I gay? Am I straight? Am I bi? Am I trans? Am I this? Am I whatever's? Am I attracted to someone who I didn't think I was? Am I a different gender than I thought I was? It pretty much goes both ways, all the ways, 10 ways.
Yeah, it would be horrible to have to figure out ways to cope silently.
Absolutely. And it's even worse when you go to get help and somebody gives you the wrong treatment and makes it worse.
Mm-hmm.
So it sounds like so often people are misdiagnosed.
Very often. Yep. Once I figured out that's what had happened to me, that was one of the things that made me go into being an OCD specialist. I was like, wow, people don't know about this.
How did you end up figuring out that you had OCD?
When I was 10, so I've had OCD since I was 4. I only know this from hindsight and remembering the things I did. Now that I'm an OCD specialist, I can go back in time and reevaluate certain things I did that I just thought were normal kid things, right? So counting in my head, another compulsion, or trying to do certain things in my head just right. Trying to protect my family from dying by doing magical rituals. Nobody saw what I was going through because it was all in my head. I now know in reverse time that that's what I had. But when I was 10, and I went into a psychiatric evaluation because I had a crappy family and was sad about it. And I was crying, and they were like, bring her in and see what's going on. And they asked me this question. They said, have you ever thought of harming yourself or ending your life? And my brain broke. My brain, I remember the moment when my brain broke. It was that question that broke it because I was 10. And I was like, what do they mean harm myself? What do they mean like, paper cuts, you fall, you get scraped. And then they said end your life. Well, I had never thought of these things in my entire life. And now this is all I can think about.
Right, up until then at 10. And then
At 10, I had never thought of that, but they said it. So then when they were like, have you ever thought about it? I was like, yes. Because I just did. Because you just asked me. I didn't say those follow-up words, and they didn't ask follow-up words. They were like, do you know how you would do it? And I just kept crying because I was so distressed at this question. And then I ended up being hospitalized. And that started a 10-year
Oh my gosh.
process.
Wow.
29 hospitalizations of over 100 practitioners not knowing what was going on with me and not knowing how to ask the right questions. So
I'm sorry that happened.
fast forward all the way to I'm 31 years old and I'm a therapist. And I was like, gosh, I knew I had contamination OCD because I was aware of contamination OCD. I knew I had that. I didn't know about these other types of thoughts that I had. I had been locked up for being homicidal. It was homicidal OCD that started at 12. All these things that kept getting misdiagnosed. So when I was 31, one day I had kept trying to treat people with OCD and not doing a very good job because I wasn't trained properly. And I Googled one day, I was like, what is the most effective treatment for OCD? And I found exposure response prevention. I went out and learned it. And in the process of learning ERP, I learned about the other types of OCD that existed. And then I self-diagnosed because nobody had done it properly in the meantime. And so that's how I got diagnosed, was I diagnosed myself after learning so that I could diagnose other people and treat them.
So once you have an accurate diagnosis, what does recovery look like for someone with OCD?
Recovery is not linear. I like to mention that. It looks like something different for everybody. Some people drag their feet very slowly in denial, like, no, this is real. I can't jump on board with this. And other people dive right in and get better fast. So, not so fun fact, OCD is not curable. You will not erase OCD. You will not eradicate OCD. You will not make it go away for the rest of your life. It looks different for different people. Some people get weeks, months, days, hours without any intrusions. And then there's people like me who get them constantly. I get intrusive thoughts every hour, multiple times per hour. There are people who can get medications that help really reduce the intensity. And there are people like me who are medication resistant and have to rely 100% on ERP to keep me going.
Okay. So it's management. It's management, not linear and not full recovery. There's no cure for OCD.
There's not a cure. Like I always call what I'm on a recovery journey, and I feel like I'm on the other side of the journey. So I get thoughts about stuff all day. It just doesn't bother. It doesn't bother me. I get the little chemical shower, but it's a little chemical shower now. It's not an overwhelming one. I don't believe what it's saying. I just move on with my day and I don't really do anything about it.
So you're able to kind of reduce those symptoms.
You can reduce the symptom intensity. You can reduce the symptom frequency sometimes, but and how you feel about it, your relationship with those intrusive thoughts. I don't think of intrusive thoughts as bad. They're just thoughts, but sometimes, because we have something called memory retrieval, your brain remembers how it used to affect you. So I might get a 10 out of 10 for something, and then I go at it with a really hard exposure and put myself right back where I was.
Mm-hmm. And I think the other, one of the other challenges too is you asked how it affects families, and so it's a natural human emotion to want to reassure. So if I told you that, and you understood that I had OCD, and I told you, I'm having these intrusive thoughts, I'm fearful that I'm going to do something to harm you, right? And say I wanted to lock up all the knives. I wanted to take all the knives out of the house because I was afraid that I was going to stab you, even though obviously I would have no intention of doing that. Because you know me, right? You would say, what would you say to me? You would say, it's not going to happen,
No,
right? You would offer,
you're okay.
Right. And
Just breathe, be in the moment, maybe go to yoga. It's going to be okay. So that's
Right.
not a good support. That's not a good support system of somebody who loves someone with OCD. We shouldn't minimize any of their symptoms that are taking place.
It would be a maybe you'll stab me, maybe you won't stab me.
Yeah.
Kind of response. And that's very challenging for someone to do, if you were to see that I was in distress like that.
Mm-hmm.
And then to be honest, I think there's always a little bit of fear that comes up in the other person too, right? Like, so
sometimes
it's challenging for sure. How do you help people distinguish between generalized anxiety and obsessive compulsive disorder? So for, people listening that maybe have undiagnosed OCD, but have been diagnosed with generalized anxiety disorder.
Yeah, that one makes me nuts, actually. And the reason is, if you are somebody who's doing some basic assessments and you put the diagnostic assessment for generalized anxiety disorder next door to OCD, they have a bunch of overlap. So people are like, yep, you worry a lot. Yep, you do this a lot. Yep. Compulsions is probably where I start to draw the line. It's not just these little, I'm not going to go too deep into it, but with generalized anxiety, there are these very specific sort of pockets of excessive worry that you do. It's more worrisome. You worry more than you should about these things and whatnot. OCD is not a worrying disorder. It's oh my gosh, something is seriously happening and I have to solve it and do something about it. It's more heavily on the compulsions side. And the obsessions are often way out there compared to what when you have generalized anxiety disorder, you're worrying a lot about whatever finances or whether somebody's going to be safe when they go away to school. I call GAD, probably not reasonable, but I call it like the worried little grandmother's disorder. That's what it reminds me of, like the grandma that's just worried about everything all the time in a very did you bring your sweater? You're going to catch a cold. That versus, oh my gosh, did you get all the knives out of the house so you don't kill the dog while I'm away at the grocery store?
I see the difference. I see the difference.
And then I think it would be helpful for people to talk about the groinal response, because I've gotten so much relief from people when you explain this to them. It's like, oh.
Sure, yeah. So groinal response, which is just a feeling or reaction in your genitals. This one freaks people out. So OCD, again, shows up in ways nobody talks about. OCD is not just intrusive thoughts. It's intrusive images, intrusive urges, intrusive feelings, intrusive smells. I get those sometimes. Intrusive feelings in your body and reactions, such as groinal response. So groinal response is through no relation at all.
Mm-hmm.
You are having a response in your genitals. It could be erections. It could be arousal. It could be moisture. It could be tingles. It could be whatever you want it to be, or you don't want it to be, but it's happening. So what explains it, high-level overview, is called arousal non-concordance. Arousal non-concordance, or ANC, is my genitals are doing something different than my brain is agreeing with, and it goes both ways. So if you've ever tried to show up, say, with a sexual partner, and you can't get your body to get as excited as your mind is, that's arousal non-concordance. Well, you can flip that over to the other side for people with OCD. Now my body's reacting and my mind's like, please no, I don't want that. And it can attach to anything. I have people I treat who they get these responses over a certain color. It could be, I have someone that gets it when they brush their hair, so they stop brushing their hair for 8 years. I have somebody who, lots of people, this is where it really tends to happen. Oh, I was watching a neighbor's kid go by and I got a response. Am I a pedophile? Am I totally into kids? Oh, I saw a pair of breasts and I'm not into breasts, but I'm having a thing about breasts and now my genitals are tingling. Does that make me a lesbian? Does it make me this because this? And so what happens with OCD is it takes two puzzle pieces, totally different puzzles,
I
and
see.
it goes, these relate. You're totally into children because you got an erection when that kid walked by, or you got an intrusive image or thought while having sex or masturbating, and you even orgasmed during that. By the way, doesn't that mean that you love that thing? And that freaks people with OCD out. And it is the absolute opposite of that. So a fun, not so fun, interesting, I'll call it, compulsion that people do, especially around sexual orientation OCD. They'll watch porn that is opposite of what they're into to do a test to see, can I become aroused by this, to see if by chance this is real. And if you become aroused, now you're like, see, I'm into this. Oh no, I am whatever. I have to leave my partner. It's very common. Right? Compared to what people are like, oh, neat and tidy. I'm like, is it? Because the World Health Organization has it listed in the top 10 most debilitating disorders for a reason. Not top 10 most awesome disorders that keep you neat and tidy.
Tracie, what does it feel like then? You've done such a beautiful job describing it. And I've learned so much from our conversation. What does it feel like? I know the reduction of the symptoms, but what does it feel like in your body when you know that someone is getting better, when some of your patients are getting better? They're not having the same fears that they once had.
Yeah, well, being that I very much work from like an evidence-based perspective, and I like to not make things up. So I have people do assessments, real assessments,
Mm-hmm.
before, during, and after treatment so that I can see the progress, and also helps break down where the areas are that maybe you're still distressed in. But what does it feel like when you start to get better? You start to start to distance yourself from those intrusions, and you start to give them less importance. So you can start getting your life back. You can start doing those things that you thought were so scary. And you just get more and more of that the further you go along in time, I should say. Until, and again, like people ask me all the time, they're like, how do you not care about thoughts about pushing your daughter down the stairs? Well, because I'm not going to push her down the stairs. That's why I love her. If I want to push her down the stairs, I will. It won't be an intrusive thought. It'll be a real action. But, you know, I'm 51 years old. I've been getting thoughts about harming others and myself for years, decades. It's not that hard to harm yourself or others. You know, it's just a choice. My values don't align with what OCD says. And so you become more and more aware of what your values are compared to what these intrusions are. It'll catch, you know what catches me off guard? It almost never catches me off guard. I'm like, whatever, this is stupid. Intrusive smells. That one catches me off guard because you don't know for sure. And so I'll go ask. I'll be like, honey, do you smell? It was turmeric, actually, not that one. Do you smell turmeric? I don't remember purchasing turmeric. Like, no. What do you mean turmeric? And I'm like, do I smell like turmeric? And they're like, can you go smell my urine in the bathroom? I think it smells like turmeric.
Right.
This really happened, by the way. I don't smell turmeric. And I'm like, okay, wait, I think I'm having an intrusive smell. Stop telling me whether or not you smell it, and I'm going to stop asking. So it just shows up in so many unique and weird ways, I think.
Yeah,
For sure.
definitely.
How have you been enjoying being part of No CD, and what is that in case people who are listening want to get help? I think the mission is awesome. The way it was started was awesome.
Yeah, No CD. So I'm a therapist at No CD. I'm the chief compliance officer at No CD. I love it. I've worked there for a little over 4 years. We're a startup company, been around for almost 9 years now. Our entire mission is to end the global OCD crisis by bringing therapy, proper evidence-based ERP therapy, to people we do telehealth only. So you don't have to drive there. You don't have to wonder if someone's within driving distance, because we just come to your whatever screen you're on. We're in all 50 states. We're in multiple countries. You can get help by going to treatmyocd.com, or you can go to nocd.com. Some of the most exciting parts about being there, I started pretty early on when we were pretty small, so it's kind of exciting to watch how large we are now. We have like over 700 therapists.
Wow.
We used to have way less. We have a whole support group program that's free for all the people who are being treated by us. I run all the taboo ones. Surprise. I know, right? Like twice a week, all I do, talk about that. And yeah, it's a beautiful mission to be on. It's beautiful to have people who care about it. Everybody that works there doesn't have OCD, but a lot of us do. And a lot of, interestingly, when we're training therapists, a lot of people through our training process will be like, wait, I have OCD in the same way that I found out that I did. And they'll be like, can I talk to you? What is it? How is it treating OCD when you have OCD? And I'm like, it's fine. Like, what do you mean? It's relatable.
I'm excited to see what roles psychedelics might play in for the ERP, not replacing, but in addition to
Changing some of those neural pathways.
yeah, and
Exactly.
locking that ERP in. So
Well, this has been a fascinating talk. I've really learned so much. Thank you both.
yeah.
Yeah, absolutely. And I always say, follow the research. Like psychedelics, my very good friend Uma Chatterjee is like cutting edge studying that, exactly that. But don't follow things that just people that you found on TikTok that say that they're evidence based. I have a lot of people that come in, they're like, I'm microdosing because I found out that this will help my OCD. And I'm like, nobody said that would help your OCD.
Nobody said that.
Nobody said randomly microdose and then come in for ERP and you're going to be okay. Nobody said that. And if they did, you were on a weird website. So, follow the research, understand what research is, understand that everything that says it's evidence-based isn't. Like, understand what you're looking at and go get the right treatments. And if somebody has treated you wrong, whatever it is, you've had a terrible experience, try again.
Find someone else. Yep. Keep trying.
For sure.
Keep trying.
And it sounds like you've helped many, Tracie. So thank you.
Yeah, thanks, Trace. And Tracie's Instagram is great too. Taboo Tracie. We'll link it.
Awesome. Yeah. Find taboo tricks. I actually talk about stuff that's not even just taboo, but mostly it is taboo.
It's good. It's good.
I do some of my own exposures on there. I always put really high level exposures on there just because to me, when you see me doing really high level exposures, I'm hoping it helps other people do low level exposures.
For sure. All right. Well, thank you, Trace.
Thank you so much.
Absolutely. Thanks for having me.